Thank you, Lisa and the FPWR, for that nice welcome. So I'm Parisa Salehi, and I'll be talking about standards of care from 0 to 9 years of age. It's a lot. Might be going a little fast because I was told I have to finish by a certain time. So I'll do my best to make things understandable. All right, I do have some grant funding from various companies, and I've been on an advisory board. So what are we going to do today? We're going to talk about what to expect for our children between 0 and 9 years of age, what to screen for, what your physicians should be screening for, I should say, who to see, and what you can do as a family. So we're going to, in PWS, a number of different systems are affected. So we can have issues with a number of different things, such as nutrition and swallow, endocrine, sleep, ophthalmology, dental, orthopedic, gastroenterology, neurologic, development, and behavior. There's a lot, and I'm going to try to go through all of them. So we'll do our best. Let's talk about nutrition. That comes up a lot, right? So the nutrition through the lifespan of somebody with PWS is very different. So what we talk about to our families with infants is very different to what we talk about to our families with toddlers and to those with a young child. And then in the next room, they talk about things differently for adolescents and young adults as well. So when we're talking about nutrition or anything with PWS and pediatrics, we need to monitor growth and development every 3 to 6 months. So it's really important to be working with a team, whether that's your endocrinologist, depending on where you are, your PCP, or primary care provider, or your nutritionist. We want somebody to be monitoring how these children are growing pretty frequently. So our colleagues in Florida came up with these nutritional phases. I'm going to briefly go through them just so you can get an idea of the evolution of the nutritional phases in PWS, because it is an evolution. So phase 0 is that time when the baby's still in mommy's tummy, and what we find is our babies with PWS, they don't move as much as their siblings when moms are pregnant with them, and they tend to be smaller than their siblings. Phase 1A is when they first are born, and they're that low-tone, hypotonic baby with feeding difficulties, and they don't have an appetite. We're trying to get them to gain weight. Later on, that starts to normalize with work and help, and we start seeing more normal or typical growth and weight gain. And then later on in the toddler years, we start seeing this weight gain, but not hunger, right? So these toddlers are not having a typical toddler behavior regarding food, but they start gaining weight if we're giving them the same amount of calories as the other 2-year-old in their daycare class. So we have to start monitoring calories pretty early to prevent weight gain, excessive weight gain, and that's because people with PWS, they don't burn calories the same as other individuals without PWS. So you can't give the same amount of calories to somebody with PWS as you do to somebody else, and that's why if you were to give them the same meal as you would your child without PWS, they would gain weight. Later on, you start to see more increase in food more increased interest in food. So that would be like asking more about, hey, when are we going to have snack? What are we going to eat for lunch? And just kind of perseverating more on those types of conversations. And but they still could say at the end of a meal, I'm full, and not finish their meal. But their mind is starting to think more about food. And then phase 3, that's what we see 8 years on average. And what I like to tell people about these nutritional phases, this is a spectrum. Not everybody is going to fit these age criteria exactly. Every child is individual. Every child is different. But these are more like averages, so we can get an idea of that evolution. So that's when kids are hungry. That's when we start seeing those kind of symptoms we talk about, and how they're looking for food, their brains are not turning on that fullness signal, and they're hungry. And so we want to prepare you all for that phase in advance, right? So we want to set you up for success, and that's what's required. And in phase 4, this doesn't happen for everybody. Phase 4, some adults will start saying that they feel full, but that doesn't happen for everybody. So it's just, we have it on there because it can happen, but it doesn't always happen. I just wanted to highlight this phase 2, what we were talking about, where you have that increase in weight without that increase in appetite, and that's specifically because of lower metabolic rate. You're just not burning calories. And so you can see this child was growing very steadily here, and all of a sudden jumped up in weight. There was no change in energy, activity, there was no change in any other health things, there was no change in the food. This is just that time when the weight started going up. And here's another example of that on a different growth chart, where you can see right around age 3, they started having an increase in their weight. And again, no change in behaviors, no change in appetite. This was all just due to lower metabolic rate. And this is just another example. And you can see that, we can get it back down. It's possible. Working closely with a nutritionist and your team, you can get that back down into the normal range. And this is just another example. All right, so let's talk about infants a little bit more in detail. So there's a term that they use in the medical field called failure to thrive. Failure to thrive just means you're not gaining weight properly. You're not gaining weight as expected. You're not following those growth curves on those growth charts that we're looking at. So it's poor weight gain and growth. This does require some children to get assistance with feeding through tubes. So you may need tubes for the first 4 to 6 months, some people even longer. And this is for safety, right? So we'll talk about that a little bit more, but we want to make sure our babies with PWS are gaining proper weight. We just want to be careful that we're not gaining too much weight, though, because sometimes we can overdo it when we're feeding calories straight into the stomach. We want to monitor for swallowing issues and safety for feeding. So we have evidence that infants with PWS, and actually through their entire lifespan, have problems with swallow. We don't exactly know why, but we know that children with PWS can have atypical swallow, meaning that when they swallow food, it might not go down the esophagus and into the stomach like we expect. It might end up into the airway and into the lungs. And that's something called aspiration. And so aspiration can cause a lot of issues in our lungs, can cause issues with feeding, breathing, and can cause even infections in the lungs. So it's something we really need to be aware of and monitor for. And so we talk about safe feeding for our infants quite a lot. So you do want to have a feeding or swallow evaluation with a specialist. So where we are at an academic center, that specialist is a speech-language pathologist or an occupational therapist or feeding therapist. So they work at our academic institution, and they evaluate how a child is latching onto a nipple, and how they are doing the suck and swallow mechanism, and how they're swallowing. And then you can even do something called a swallow study. A swallow study is an X-ray, basically, where they put a little bit of contrast in a liquid, like a milk, and then they turn on the X-ray for short periods of time so that you can see the child swallowing and see where it goes. And we can tell at that point if it's going down into the esophagus and stomach like it should be, or if it's going into the airway. And if it's going into the airway, that's dangerous. So you do need to work with skilled nutritionists to ensure that the infant is getting enough calories for growth without causing too much weight gain. They also need to be monitoring the nutritional content. You want to make sure you're getting all the nutrition, the right amount of calories, the right amount of fat, protein, carbs, and vitamins in their feeds. And as I was saying, we want to work with a therapist, a feeding therapist, to work on oral skills. So we want those kids to practice. Working with a binky, taking small amounts by mouth in a safe way, because we want them to work and improve those oral skills. Our kids can tire easily when feeding by mouth, so that's something else we tell families. You don't want to feed them for more than 20 minutes at a time, because they can get really tired. And the more tired they get, the more likely they are to aspirate because they can't protect their airway. So you don't want to try to feed for longer than 20 minutes. And then, as I was saying, in that phase 2, we want to start restricting our calories so that we're not getting that excessive weight gain. Typically, it can be anywhere from 60 to 80% of the calories that somebody without PWS is getting. It's very individual again. Some of our individuals with PWS can be more on that 80%, some are more on that 60%. So again, it's really important to work with your team, your nutritionist, to see where that sweet spot is for your child. Fiber. So I did a poop talk yesterday for the other providers. There's just a lot of pooping issues. There's a lot of constipation. One of the things is we don't have enough fiber. I mean, hardly any of us have enough fiber, but our kids with PWS don't get enough fiber. They don't get enough fluids. So you want to make sure you're getting at least 20 grams of fiber per day. You want to monitor and make sure on a restricted diet you're getting enough calcium. You're getting enough vitamin D. You're getting enough iron. Now, the group from Florida also looked at what we call the macronutrients. So macronutrients are your protein, fat, and carbohydrates. What proportion of those fits best for the needs of somebody with PWS? So typically in a toddler, your carbohydrates, so that's your breads, your starches, your pastas. As you know, like anybody with a toddler, they just want to eat carbs, right? Typically it's 65 to 70% of their diet, but they did a study showing that if you were to give a little bit less carbs and more fat and protein, that helped to keep them full longer, so somewhere closer to the 45% carb range. So the other things we talk about as we move into the older age range, right? So now we went from infants, we went to toddlers, and now we're in the little bit older age range than childhood. So some of the things, the key things we talk about in terms of food management and diet management include behavioral modifications, dietary control, exercise, and close supervision and restriction to food and money. So these are scaffolding that you can put in place into your lives to help protect your children and to help keep what we call a food secure environment, right? So this includes things like having schedules and routines. I mean, in general, it's really good to have schedules and routines for young children. Our children with PWS really love schedules and routines. And so always having your breakfast at the same time, always having that snack at the same time, always having the lunch at the same time, having rules about it. You can even, start teaching them how to read a clock by saying, well, where's the clock? What numbers are on the clock? What's the shorthand and the longhand pointing to? Is it time? It's not time. So that helps redirect your children as well, so that they're not as focused on it. And then the dietary control, like we talk about, like knowing how many calories they're eating a day, making sure you're working with your daycares, your schools, your family members, your other caregivers to make sure that they're all on the same page with how big the snack should be, how big the meal portions should be. Exercise is really key. So exercise is really good for the muscle strength, right? So really good in building, our kids already have low tone, so you want to build up the muscle strength for them, right? It also helps burn calories. So it's it's multiple reasons why we want to do exercise. Close supervision and restriction to food and money is really important. So that's when we start talking about securing your food in your home. So I always talk to our families about doing it preemptively. And the reason I say that is at the point where it becomes a problem, you don't want to start locking food and then your child thinking that it's a punishment. We don't want them to think it's punitive, that they were being bad, right? We want them to be like, this is just how my house always is. This door is always closed. This cabinet's always locked. This fridge is always locked. We don't want them to think that this happened because they did a certain behavior. We want them to just know, my house is always secure. This is a picture to illustrate how complicated the pathways in the brain are for appetite and feeling full and feeling hungry. So appetite and satiety. It's really complicated, and we're still not fully understanding all the pathways and hormones in it. But what we do know from the studies that we have done is that individuals with PWS, when they eat, and we've done these studies of the brain as they're shown pictures of food and things like that, their brain, areas of the brain that are involved in reward, they light up, brighter than people without PWS. So their brain is like, yes, food, so they're rewarded with good feelings. They have delayed satiety, meaning it takes longer, it takes more food for them to feel full. And then they have decreased inhibition, right? So that means like those signals that tell them to be like, hey, it's enough, enough is enough, that doesn't work as well. So this combination leads to hyperphagia. So that's what's going on inside your child's brain, right? So no wonder they're hungry all the time. Like these three mechanisms lead to that. So again, so our current management, what we're doing right now, consistent rules, schedules, and restriction to food. Knowing expectations decreases food anxiety. So food security is about decreasing food anxiety. Your child, if they're always hungry, they're going to want to know when their meal is coming next, because they want to know that they're going to get food. They're going to know what kind of food they're going to get, when they're going to get it. Are you sure we're going to get food if we go here? So it's food anxiety, right? So if they know their schedules, they know rules about food, they know when their food is coming, that helps decrease the food anxiety. So there's a group in Pittsburgh that it's been a while now, I think a couple decades, that came up with this philosophy to explain the ways to decrease food anxiety or your food security. It's called no doubt, no hope, no disappointment. We've gotten feedback from our families that they hate the term no hope, and I get it, right? We're not saying there's no hope in having treatment or management. It's no hope in getting food. So no doubt means you always know when your food is coming. Your breakfast, your snack, your lunch, your midday snack, your dinner, they're always at the same time. So you're very consistent about that, so they always know it's coming at a certain time. No hope, no chance means no chance of getting food. That's the food locking, right? So if they know the food is locked up, they're not going to try to keep you trying to find the food or get to the food. We've actually had some of our older individuals with PWS in the teenage years and young adulthood have actually told us, hey, when my teacher doesn't lock up my food, I get very anxious. It really stresses me out because I'm always thinking about, oh, it's not locked, I can go get it, right? But when the food is locked up or put away, the temptation is not there, they can focus on something else because they know that there's no way to get to that food. No disappointment, that's on you all. So if you made a promise for them to get that popcorn with that movie, follow through with that promise, because you want them to believe you for the next time, right? So you want to make sure that you're not disappointing them so that they know that when you say you're going to give them something, that they're going to get it. Okay, now we're going to go into the endocrine. That's my field. So we're going to talk about it in two sections. Mostly we're going to talk for the younger age group. We're going to focus on the hypothalamus and pituitary. So these are areas of the brain, central, right? If you were to do a cross-section this way and this way, it's right in the middle of your brain, in between your eyeballs. And this small area of the brain controls a lot of hormones. It controls your growth hormone, your puberty hormones, your thyroid hormone, and your hormones involved in that control something called cortisol. And we're going to talk a little bit about all of these, mostly about growth hormone, just as a warning. But these hormones in that area of the hypothalamus, they're affected by that difference in our kids' genes on chromosome 15. That area of chromosome 15 that's different in PWS affects the way this area develops. And that's why we have different hormone deficiencies, because that area regulates those hormones. It also regulates sleep. It also regulates appetite. It's probably regulates a lot more things that I'm forgetting at this moment. But that's why we see a lot of the things that we see in our individuals with PWS. The pancreas. So we talk about the pancreas when we have weight that is uncontrolled. So if your weight is more than it should be for your height and you end up having obesity, then you can have complications related to high blood sugars and type 2 diabetes. So what do we know about growth hormone? Growth hormone is lower in people with PWS. It's just accepted at this point. There's been so many studies that have shown that it's decreased in PWS that the FDA doesn't require you to prove it. So you just need the diagnosis of having Prader-Willi syndrome to get growth hormone in the US. So you don't need to do testing for it. If you don't get growth hormone, you do end up shorter than expected for your family. And it's been an FDA-approved indication since the year 2000. And we know that it works, gives benefit as early as infancy. So for us, we really push starting growth hormone as soon as we can. The benefits we have in infants, it improves growth for head size, height, and body proportions. We know it helps in acquiring skills, so you start crawling a little bit sooner than you would have if you weren't on growth hormone. You start walking a little bit sooner if you weren't, instead walking a little bit sooner compared to those who don't get growth hormone. And it helps them with language skill acquisition a little bit sooner. What I will say to families, it's not going to be the same as your child without PWS. But it'll be better than a child with PWS who didn't get growth hormone, if that makes sense. Also, we know it improves intelligence scores. Children who got growth hormone before the age of 2 compared to those who didn't had better IQ scores. And we think this has to do with the fact that growth hormone stimulates a protein called IGF-1, which I'm sure you all have heard about and talked about with your endocrinologists, because we use it to monitor growth hormone, but the IGF-1 actually, we know, helps with brain development. So that might be one of the reasons that it helps with those IQ scores. It helps with breathing. You know why? You can take a deep breath. So those floppy babies who aren't strong enough to take a deep breath, like, once they start growth hormone, they can take those deep breaths, and that helps with breathing. Now, I put a star on there because there is a small portion of people who are born with a condition called laryngomalacia, which is a floppy airway. This floppy airway is not caused by growth hormone, but as soon as you start taking that deep breath, that airway starts to flop more. And so you start getting this kind of noisy breathing, what we call stridor. It says, so we've had some families that are like, hey, now our kid is breathing noisy since they started growth hormone, and that's because they're actually strong enough to take a deep enough breath to have that floppiness. And that's not from the growth hormone, but it can cause what we call obstructive sleep apnea. So it is one of the reasons we do recommend having some kind of sleep test before and after starting growth hormone. In toddler years and older children and adults, we know that it continues to improve body composition, and your BMI is that average, it's that ratio, I should say, between your weight and your height. It improves cognitive functioning, and you get closer to your family height. Here are the things that are indicated for stopping or not starting growth hormone. So severe obesity, and nobody's ever defined this. We leave it up to clinical judgment. Uncontrolled diabetes is one because growth hormone can increase your blood sugars or cause more insulin resistance. So we want to make sure your diabetes is controlled before we start growth hormone. That doesn't mean if you have diabetes, you can't be on growth hormone. We just want it well controlled. Untreated severe obstructive sleep apnea. So for our older kids who have tonsils and adenoids that are causing sleep apnea, if you were to start growth hormone can make those bigger. And so we don't want that getting worse. So we want that treated first. Whether it's to remove the tonsils and adenoids if they're large, or getting on a CPAP or BiPAP to make sure you're getting enough oxygen when you're sleeping. And then active cancer, active psychosis are some other ones. So there's some controversies about growth hormone that have come up in the past decades. Is there an increased risk of death? So this comes from there was a mortality study done where they looked at sudden death in children with PWS, and there were 64 cases of sudden death. Sudden death meaning unexpected. They weren't in a hospital with pneumonia. It just happened, and we're not exactly sure why. Half of those cases were on growth hormone, half weren't. So we don't think there wasn't an increased risk of it with the use of growth hormone, but what they did find is for those who were on growth hormone, the majority of the deaths occurred in the first 9 months. So then it begged the question of, well, was there something going on with the growth hormone that might have precipitated this? The most common cause in children is respiratory illness. But when they looked at the differences in the growth hormone and untreated and treated, there was no difference between sleep apnea, gender, obesity. So they came up with hypotheses because nobody really knows why these children died. Was it due to worsening sleep apnea? Was it due to an adrenal crisis? They don't know. And because of that, this is why one of the reasons we check sleep studies before and after starting growth hormone. Scoliosis. So does it make your scoliosis worse to be on growth hormone? There was a small study out of Europe that showed that individuals with PWS who got growth hormone versus individuals with PWS who didn't get growth hormone had the same rates of scoliosis, and the worsening of their scoliosis was the same. So the way I talk to families about it is this, this growth hormone is not causing the scoliosis. If you're growing, that curve in your spine is going to grow. And so you need to get it monitored. So you need to be following with an orthopedic physician. The risks, the benefits of growth hormone are so great, you don't want that to be the only reason you're not on growth hormone. So you just need to monitor it closely. Some of the things that you would expect if you're on growth hormone treatment is you would get regular blood work or labs. Bone age is something, an x-ray of your hand to monitor how your skeleton is maturing over time. You get every 1 to 2 years. The scoliosis evaluation, and then sleep apnea evaluation. I want to know if you have sleep apnea, and I want to know if it's getting better or worse. So I work very closely with our sleep team, which in some centers is your pulmonary team, and sometimes with an ear, nose, throat doctor or otolaryngologist who might take out your tonsils and adenoids. So this is the sleep study that we were talking about. You want to start before growth hormone and 6 to 10 weeks after starting growth hormone, and you repeat it. Some places repeat it yearly, but some places repeat it based on symptoms. If your weight has increased quite a lot or you're having symptoms of snoring, then you definitely want to get another sleep study. So this is the dosing. I'm not going to get into the details of it. What I will say is the doses and responses are variable. So every child needs to be treated individually. Not the same dose for a 1 2-year-old is not going to be the same dose for another 2-year-old. Some of our children with PWS still make some growth hormone. You want to adjust the dose based on what their bodies need, and so you get that from blood work. So I always tell families, don't compare how much the other child with PWS in your group is getting compared to yours. You get what you need to get based on your blood levels. So every treatment is individualized. You want to monitor your blood levels for your IGF-1 at least twice a year. We also want to monitor x-rays for scoliosis, the bone age. We want to monitor for those sleep apnea symptoms, which could be snoring or pausing in breath. So snoring is if you have new snoring, you definitely want to bring that up with somebody. But sleep apnea also is sometimes just pauses in your breathing like this. So if your kid is doing that, you need to bring that up with your endocrinologist or your sleep provider. And then if your weight is elevated, we're also going to be monitoring things like your blood sugars. Puberty, that's the next most common hormone problem in people with PWS. So individuals with PWS, whether male or female, can have incomplete, delayed, or disordered pubertal development. For boys, that could look like a lot of our boys have undescended testicles. That's not usually a surprise when boys are born with undescended testicles. They can also have small testicles or an underdeveloped scrotum. That's due to the lack of testosterone or not enough testosterone. In girls, that looks like an underdeveloped labia or clitoris. As they get older, they might not have periods on their own, or they might have abnormal periods. So that's more in the 10+ talk over there. So special considerations for males in the infancy is the undescended testicles. I want to bring this up because if you have a little boy and they don't have their testicles in their scrotal sac, that needs to be monitored. If they're still not down by 6 months of age, you definitely want to see a urologist or a specialist to bring it down. And here's why. We don't expect fertility in our boys. So testicles, if they're not in the scrotal sac and they're up in the body, they're too hot. It's too hot. The inner body temperature is too hot for testicles, and it can damage them. So we're not so much worried about damaging for sperm production, but we're worried about damaging for risk of testicular cancer in the future. So you definitely want to bring those down. And if they're not down by 6 months, they won't come down by themselves and they'll need help. So a little surgical procedure for that. So some infants, some boy infants with PWS, you might hear about something called HCG. It's a hormone. It has been used to help develop the penile length, the length of the penis, and to make a more developed scrotum. There has been some discussion about it helping to bring some testicles a little bit lower. Here's what I'll say. It doesn't work really well for that purpose. If your testicles are up high that your doctor can't even feel them in the groin or anything, it's not going to bring them all the way down to the scrotal sac. It might, if your testicles in the groin, it might bring it down into the scrotal sac, but don't be surprised if it doesn't. And testosterone injections can be used if your penis is small. You might want to do that if you have what we call a micropenis. We base that on the size. The reason you would do that is later on it might help with potty training if their penis was a more normal, typical size. We talked about this. Okay. Here's one thing I want to point out. Even though we talk about most puberty is delayed or incomplete, you can have early puberty. So this is something we monitor for and that I talk to my families about. So early puberty is defined as changes of puberty before the age of 8 for girls and before the age of 9 for boys. Typically what we see, actually pretty commonly, is early pubic hair. So if you start seeing some curly pubic hair down in the diaper area and the private area at 6 or 7, that's actually something we do see pretty commonly in PWS. You do want it to get worked up to make sure we're not missing something like a problem with the adrenal gland or true central puberty, which I'll explain. True central puberty is when you start making estrogen and testosterone. Pubertal hair can come from hormones from your adrenal gland. So it's important to differentiate those two. So you want to bring it up to your endocrinologist, and somebody should be checking down there at least once a year. I know it's always embarrassing, but I always try to normalize that. And then if there is early puberty, you want to screen and make sure we're not missing something abnormal. Okay, let's talk about the thyroid. Now we're going to this gland here in our neck. It's in the shape of a butterfly, but it's controlled by that area in the brain of the hypothalamus and pituitary. This is old data. I was just talking about this with my other endocrine colleagues. Old data says that in 20 to 30% of people with PWS, the thyroid levels can be low. So that signal from the hypothalamus and pituitary is weak, just like your growth hormone secretion is weak. So if this signal from your hypothalamus and pituitary is weak, it's not telling your thyroid to make as much hormone as it should. And so I actually think it's a little bit higher than this, but we haven't reviewed that data. The average age of diagnosis and treatment is about 2 years of age. I start checking this in infancy, and the reason why is that thyroid hormone is really important. It's important in energy, it's important in metabolism. If you have low levels of thyroid hormone, you can have lower energy, you can have lower metabolism, you can have constipation, dry skin, poor growth, and in infancy, it's really important in brain development. So I definitely want to make sure my infants are getting enough thyroid hormone for their brain development. So you want to monitor thyroid labs yearly after 2 years of age. In the first year of life, I do it about every 6 months. And you treat with a medication called levothyroxine. It's thyroid hormone that's synthetic, just like your growth hormone. It's the same as it's a replica of the hormone your body makes. It's very safe, very easy to take. Okay, this is the most rare. Problems with your adrenal gland are the most rare, but it can be severe. So that's why we talk about it and we screen for it. Your adrenal glands are these glands on top of your kidneys, and they're also controlled, the hormone cortisol that your adrenal gland makes is controlled by that area of the brain. There's really mixed results from studies about how frequently adrenal problems happen in PWS. There's one group in Europe who thinks it's very high, and nobody else has been able to replicate that data, but because cortisol, which is the hormone we're worried about, is super important in what we call your stress response. So that's the response we have when we're sick. So if your body is under stress, your body makes cortisol. That cortisol helps increase your heart rate, increase your blood pressure, so your blood is flowing more and your body can help fight that stress. So if you don't have enough of that cortisol and you get sick, that can actually be very life-threatening. So we do want to make sure you're making enough cortisol. We do know that children with PWS can have low cortisol levels. We do know that there have been some autopsy reports of children who died that had smaller adrenal glands, and we're not sure if that was related to their cause of death or not. So we do recommend screening at least once a year. So typically what we do is we get a morning cortisol. Cortisol is always highest in the morning. So you want to try to get it between 7 and 9 in the morning to get the peak level. And then if that's low, then we might do something called a stimulation test where we give you a dose of a medication that should make your adrenal gland make cortisol. And then we test that level an hour later, and then we see if your adrenal gland is making enough. You can also test cortisol and another hormone, that's the hormone from your brain that stimulates cortisol, called ACTH, during illness, because when you're sick, your body's under stress and you should be making more cortisol. So that's another time you can check it. For those times where you're not sure if the kid's cortisol level is normal because nobody's checked it, but they're going for a major surgery, sometimes we'll say, well, if we don't have time to screen for that and make sure it's okay, we might give you cortisol as a medication called hydrocortisone prophylactically. Okay, blood sugars. There was a study in France many years ago that showed that blood sugars in children could be abnormal, but typically we don't see things like diabetes until your BMI or your weight is very high for a while. We screen this if your weight is high with labs and something called an A1C, which is a 3-month measure. Okay, let's move on to sleep. So what are the problems we see? What are the consequences? And what do we do to screen and treat? So we see something called central and obstructive sleep apnea. So sleep apnea was that pauses in the breathing that I was talking about. Central means that it's the brain signal is not telling you to breathe properly. Obstructive is when it's blocked. So that might be from the low tone, floppy airway, or from the big tonsils and adenoids. All our children with PWS also have other types of problems with sleep. They fall into deep sleep much faster. They can have abnormal sleep patterns. Our babies especially can have low oxygen when sleeping, so they might need oxygen when they're sleeping. And they have when they get older, they have something called excessive daytime sleepiness. So they might not have problems sleeping at night, but they're really sleeping during the day. They fall asleep in cars, they fall asleep at school, they need naps all the time. And this is kind of on the verge of what we call, on the verge of narcolepsy, and so that's something that might need to get treated. In less than 2 years of age, just like nutrition looks different at different ages, sleep looks different at different ages too. So the majority of infants under 2 have that central sleep apnea. And this starts to become much less frequent after the age of 2. Sometimes children with central sleep apnea could have seizures. So that's something that your sleep study actually screens for, is seizure activity. Growth hormone may be associated with changes in these sleep study results, better or worse. For the most part, if it's central sleep apnea, it makes it better. But like I said, there are some cases we've had where it got worse because of that unmasking of the laryngomalacia. But typically, there's no change. And so we do recommend having a sleep study checked 6 to 10 weeks after starting growth hormone. If you have worsening obstructive sleep apnea, you definitely want to see an ear, nose, throat, or otolaryngologist. Over 2 years of age, obstructive sleep apnea is the most common cause of sleep apnea. If it gets worse, you definitely need to evaluate the tonsils and adenoids. And some of the reasons to evaluate for sleep apnea are not sleeping well, snoring, daytime fatigue, and if the weight is going up very significantly. Some of the other things we see in our older children are that excessive daytime sleepiness we talked about. Over 60% of adults have this excessive daytime sleepiness. And then sometimes that can go to the extreme side, which is called narcolepsy or cataplexy. Cataplexy is you have that excessive sleepiness, but it's associated with something emotional. So somebody finds something very funny and starts laughing really hard, and then they fall asleep. So that's called cataplexy. It's kind of odd. It's kind of like startling to witness the first time. Insomnia, getting up at night to eat. So our kids are not getting restful sleep if they're getting up at night to eat. Also, we have a lot of our kids have restless leg syndrome, which is associated with low iron stores. So this is just like moving around a lot at night. So you want to make sure your sleep pulmonologist is also checking your iron levels. So the reason we just focus on sleep a lot is respiratory-related problems are the highest cause of serious events and deaths in infants and children with PWS. In adulthood, it's things associated with high weight. But in children, it's associated with sleep and respiratory problems. Poor sleep can affect how they function day to day, like during the daytime. So it can affect your energy, your wakefulness, your ability to concentrate, your engagement, your mood. That's why I need my 3 cups of coffee in the morning, so I can be able to talk to you all and function. Chronic untreated sleep apnea can actually affect your heart. So you can get something called pulmonary hypertension, can have high blood pressure, and it can also increase your risk of diabetes. So we definitely want to be monitoring symptoms and following with a sleep specialist. You want to get regular sleep studies. And treatment varies. It could be surgical, it could be a mask, CPAP or BiPAP. Here's what I'll say. If you think your kid can't do it, don't say they can't do it until you try, and then try again. Because there's different masks, there's different ways that it fits on your face. There's actually therapists that work with helping children learn to wear it at night. So work with your sleep team. Just don't give up right away. And if you have that excessive daytime sleepiness, there's medications for that now. And then careful monitoring is needed. Okay, we're gonna go through all the rest now. Bear with me. Poop. Poop is a problem. Constipation is frequent in at least 30% of our patients. It's a perfect storm for constipation. We have low fiber, low fluid, low tone, and slow transit. So food and poop just move slower, so it just gets held up. So pooping once a day is not enough. You need to poop like twice a day. If you're not pooping enough, you get distended abdomen, pain. Rumination is when that feeling that the food is coming back up. Rectal picking, because our kids something feels weird in their bum because they're impacted, and so they start picking at it. You want soft poops that look like a smooth sausage. That's the Bristol type 4. That's the goal of all the poop doctors. Mushers and pushers. These are different types of meds. So mushers are the medications like Miralax or polyethylene glycol, the generic. That's the one that makes your poop soft, but it doesn't move it through. It just makes it soft. So if you are only focused on that and you give too much of it, you could have lots of runny poops and accidents. Sometimes what our kids need are pushers. So these are our laxatives that make your bowels contract and move things through, because our kids' muscles are just not moving things through. So this is things like X-Lac or Senna. You give it at night, wait 8 to 10 hours, wake up in the morning, and have some quality toilet time in the morning. And that helps move things along. Swallow. So this is that dysphagia or aspiration I was talking about. Dysphagia means abnormal swallow. So that could be in the mouth, where you're not doing the typical coordinated muscle. There's so many muscles in your tongue and your mouth, and they all have to coordinate for you to be able to swallow properly. And a lot of our babies don't have that coordinated swallow, and they need to work with a feeding therapist to build those skills. Silent aspiration is when you get that food down that airway we were talking about that's dangerous for your lungs, but typically you should be coughing. If something have you ever had you start laughing while you're taking your drink and you start coughing because your food went down the wrong airway? That coughing is your evolutionary mechanism to protect yourself from aspirating. Our kids with PWS don't have that. That food is just going down and they're not coughing. You don't know what's happening. So our families are like, but they're eating, but they're not coughing, they're not looking distressed. That's because it's silent. So that's why we want to be really careful. That laryngomalacia, that floppy airway, we talked about that a little bit already. That can cause that sleep apnea, as well as it can also cause problems with swallow. So you definitely want to be looking at a swallow or feeding evaluation and studies as needed. Orthopedics, these are the bone doctors. Hip dysplasia. This is an abnormal or underdeveloped hip joint. So your hip socket should cover your whole, like that, the ball socket should cover the whole ball part of your femur or your thigh bone. 20 to 30% of our babies that are born, that bone covering the thigh bone socket is not formed all the way. It's underdeveloped. That can cause your hip to get dislocated. So we do recommend getting hip ultrasounds to screen for this. After 3 to 6 months, the hip ultrasounds aren't as good, so you want to do the hip x-rays. And then typically, you want to monitor this with orthopedics for sure, not just your endocrinologist. But what we do find is that typically if you keep monitoring it, though it improves over time, but sometimes it doesn't, and you have to do something like this really beautiful brace called a Pavlik harness, and growth hormone might help as well. So a lot of times the treatment is observation versus bracing or casting. The other thing is scoliosis. A lot of our kids have scoliosis, whether they're on growth hormone or not. This is an x-ray showing a curve in the spine. When we get those scoliosis x-rays, that's what we're looking for. Again, no relationship between growth hormone treatment and scoliosis severity, so having scoliosis should not prevent you from getting growth hormone. I monitor this about every 1 to 2 years, starting at the time that they can sit up. So between 1 and 2, I might get the first one. Sometimes they can't sit up, so I'll just have the x-ray tech kind of stretch them on a table just to get an idea, because we want early intervention with bracing if we can. If abnormal, we refer to a specialist for evaluation and treatment. Teeth. How many of your kids have cavities, no matter how much you brush them? Our kids with PWS are prone to cavities, and here's why. They have bad enamel. They're just born with bad enamel, and that saliva is thick, and it sits there with that bad enamel, and you get cavities. So you want early and frequent checks with your dentist, and more frequent cleaning. So, it's like the dentist says come every 6 months for cleaning. You might need to go every 3 to 4 months for cleaning. Eyes. So you can have all sorts of eye problems. Strabismus is the crossing of eyes. Myopia, hyperopia is more like the distance. Cataracts, nystagmus, these are all seen in people with PWS. You want to make sure you're seeing an eye specialist. Strabismus, that crossing of eyes, you should get that treated as soon as you can. Our infants, sometimes they have the crossing of eyes, whether they have PWS or not, and as long as it goes back to looking straight, it's fine. But if it stays crossed, then you definitely want to see an eye doctor, because if you don't correct that surgically, it can affect their depth perception in the future and make it harder for things like depth perception, reading. So you definitely want to fix that as soon as you can. Neurology. Seizures, especially during fevers, can occur pretty frequently in PWS. You also have a pretty high rate of what we call epilepsy, which is just a seizure disorder whether or not you have fevers. So when we do our sleep studies, we always do an EEG, it's not a full EEG, a partial EEG, and we do see abnormalities or atypical EEG patterns I know that's a big range just because of different studies, but in a fair amount of people. And it might improve with age. In behavior, there's a number of different behavior issues that are seen in PWS throughout the lifespan. Typically, a lot of this is seen in the older kids, but you might start seeing things like stubbornness and temper tantrums. Our kids love routines, and they have some compulsivity. The skin picking can start occurring in the earlier years, but you can distract, or you can keep their hands busy with fidget tools. Some of our kids are more on the spectrum of autism, and so what I tell families is their characteristics might just be PWS, having PWS, but it also is a lot on the autism spectrum, and guess what? The autism support groups have done a really good job of advocating for insurances to cover things like ABA therapy. So it's sometimes worthwhile to get that diagnosis so you can get those extra services. Psychosis can be seen in some patients in young adulthood. ADHD is actually pretty common, and I would say underdiagnosed. So some of our kids who get that ADHD diagnosis and then get started on ADHD medication, guess what? The parents are like, oh my gosh, the behavior, the impulsivity. It was that impulsivity that was causing behavior issues at school, so that treating that was helpful. Those meds don't help as much with the weight loss and appetite as you see with the typical kids, but but it can help with impulsivity. Catatonia is something else that's very rarely seen. All right, we want early socialization, we want routines, we want limit setting, we want to work with a behavioral specialist if you have that available. Again, if you have a suspicion for ADHD, ADD, or autism, please get evaluated for it because you want to get treatment. In terms of development in school, we start seeing developmental delays starting in infancy, right? Like not sitting up at the typical time, not talking at the typical time. So you definitely want to start tracking that. A lot of our children can have mild to moderate intellectual disability and learning disabilities. So you want to make sure you're giving them the supports they need at school. So that includes having an IEP, individualized education plan. I always get the I wrong. Did I get the I wrong? Okay, good. And so you want to make sure they have the supports at school. The supports aren't just for learning, it's also for food security. In your IEP, you advocate for food security. They have to have a one-to-one to take them to the bathroom, to go to lunch. They need to have somebody with them sitting down. The lunches can't be somewhere that they can pick, go and grab it. Like they can't have a snack area that all the kids can go and grab snacks. These are things that you do to advocate for your child, and those are within your rights. So put that into their IEP. Okay, early intervention services. We love early intervention services. So that's your physical therapy, your occupational therapy, your feeding therapy, between your birth and to 3. So every state is a little bit different. Our early intervention services are 0 to 3, and then after that, the school district takes over those services. So make sure you're in early intervention early, get as much as you can. More is better than less. So I say if you want to get more, go for it. Hippotherapy, aquatic therapy, and other things are also really great. Hippotherapy helps with core strength. It's actually a type of occupational therapy. Kids love working with the horses. Aquatic therapy is something else for kids with low tone and even with higher BMIs. It's a really great way to work your muscles and exercise. Again, work closely with schools, have an IEP, and advocate for your child. The best advocate for your child is you. And if you need help, talk to people who have experience, but advocate as much as you can. It takes not a village, but a city, right? We just went through all of these different things, and I went through it really fast. And so you really need to be working with a lot of different disciplines. And reach out for help if you need it. And take care of yourselves. Caregiver burnout is real, and it is high in PWS. You can't take care of your kid if you can't take care of yourself, right? So make sure you take that time. Make sure you apply for your respite care. Make sure you have caregivers who can support you and take care of you. Make sure you take some time off. Go get that massage. Go on vacation with your partner. Like, take some time for yourselves because you have to be able to take care of them by taking care of yourselves. Thank you to all of my team, the FPWR, my models, all of those pictures, except for the dental one. I couldn't find a good dental one, were kids in our clinic. So I'm open to questions if I have time. You have about 3 minutes. 3 minutes. I see a hand over there. Oh, I don't know. I don't know what the rules are. What are the rules?
Yeah, up to the mic. Hi, so I'm Janelle, our daughter is 4, and one of the things when we always look at standards of care is nutrition. And one of the questions I have, it's so varied. There's some general rules, but it's so varied on a day-to-day of what parents will give. Is there some studies that kind of looks at the variability with regards to what parents have been given and then kind of like the impact on the hyperphagia onset?
Yeah, no, great question. Like variability between what one clinic says versus another clinic?
Not necessarily what one clinic says or promotes, but essentially what parents are actually giving their children.
Yeah, I don't think anybody's given, besides that study from Florida I pointed out, what we talk about is we want a healthy, balanced diet for your toddler or whatever age that's appropriate, but you just probably less amounts of it. So that's why we talk about working with your nutritionist. and I see a couple of my families in this audience, and I know they hate it when we ask for food logs. We ask them for food logs so that our nutritionist can actually do an analysis of what they're getting. Are they getting enough fat, protein, and carbs? Are they getting enough vitamins? Do we need to add a multivitamin? So it can vary, and that's why we don't expect you to be a nutritional expert, right? Some of our families do become nutritional experts. But what I would say is work with your nutritionist, come up with what works for your child, and it might be adjusting portions or maybe switching out one snack for another snack. And so it depends. Like, it's very dependent on that child. Like, not everybody's metabolism is the same either, or everybody's feeding abilities are the same. So that's why it's hard to answer that question. Nobody's done a head-to-head study, but it's just important to work with that expert who knows what to give your child. And you know just as well. It's more about working with what works with your family.
This is more of a logistical question. We have a 3.5-year-old daughter who does not have PWS and a 10-month-old son who does have PWS. So how do we introduce food security into a home with a toddler who's very comfortable getting her own food without creating resentment or an eating disorder for the older child? How
oh my
do you
gosh, this is a
introduce
whole
that?
different talk, right? So you talk to any of the parents here with older children with PWS, you're going to talk, they'll tell you that the siblings are affected so significantly, right, in the household, because you're right, you're talking about food all the time. You're securing food, and you're fighting about food, right? And so it's hard. It's really hard. What I would say is the schedules, food routine, it's just, I think if you can create that environment early, then the other children will also accept it. And then once they're old enough to navigate kind of the thing, you don't want to put any responsibility, obviously, in a child, but talking to them about, like, sometimes you and I will have our special snack somewhere else, right? Just so, because you want it to be out of the sight of your child with PWS, otherwise that's going to cause some tension. It's difficult. I don't have a good answer. But it's just more about working with that person. But I want to acknowledge it's really hard, and it's really tough on the siblings. And I think any of our families with the older children will tell you that, yeah.
Okay, thank you.
Hi, we have a daughter, Elodie. She's 5. She's been on growth hormone for about 3 years. We caught it kind of late. We did not do a sleep study, and we have a monitor in her room, and we were basically told, like, if you hear her snoring, like, these are signs and symptoms, but should we be doing a sleep study? Should we have done it? And is it too late? And how long do you have to monitor for, how?
It's never too late to get a sleep study. You can't change the past, right? So what, I think I would say it's important to talk to a sleep specialist. If you're not seeing a sleep specialist, I would, just to make sure that somebody is monitoring it and evaluating if you need that sleep study.
Thank you.
Yeah, there's just enough disordered sleep that sometimes you can't catch it. I mean, having a baby monitor, you have to sleep too. Like, you're not going to catch everything. You have to sleep too. So yeah, let the professionals figure it out for you.
Take one more final question.
Hi, we have son, 14 months old. So one of the slides says starting dose for growth hormone 0.5 mg. Is it that's the starting dose, or can it be lower?
Oh, yeah, sorry, I went through that very quickly because I don't expect you all to do the dosing. Milligrams per meter squared per day. So it's 0.5 milligrams per meters per squared. So meter squared is the body surface area that we measure. It's a calculation we do based on the length and the weight of a child. And typically an infant is anywhere from 0.2 to 0.3 body surface area. So you would do 0.5 of that per day. So the starting dose could be anywhere from 0.1 milligrams a day to like 0.15 or 0.2 milligrams per day, depending on the size of the child. For instance, in infancy. So it's based on a calculation we do.
And at what point we see change in the dosage of growth hormone? Because our son is getting same dosage since he was 3 months, and now he is 14 months.
It depends on the levels that they do with their blood draws. So we follow something called an IGF-1, and some places also do something called an IGF-BP3. And so you want to change the dose based on where those levels are. So it's possible. I've had children on the same low dose for a long time because based on their IGF-1 level, they're already at the top of the limit. And if I went any higher, they'd be way over normal for their age, so I don't need to go up.
Thank you.
Sorry, I went over.
No, you're fine.
All right. Thanks, everybody.
Thank you, Dr. Salehi. That was very informative, and there is a lot to know about PWS, so I'm sure you're left with additional questions, and perhaps she wouldn't mind being asked some questions. Okay. For the person that asked about siblings, I just wanted to mention to you that FPWR did a study that we're going to be sharing information about at this conference related to the impact of having a sibling with PWS on the non-affected siblings. So that may be something of interest to you, and we'll be sharing that with the greater community. Again, I want to thank Dr. Salehi for her infinite knowledge and her generosity in coming and talking with all of us today. I just want to take a couple of moments real quick to introduce you to those that may not be aware. FPWR manages something called the Global Prader-Willi Syndrome Registry. This is a really wonderful way for you to get involved in research from the comfort of your home. And I cannot stress enough the impact that participation in this registry has on all aspects of PWS research. So this registry launched in 2015. We currently have over 2,000 participants. This is a way for us to gather information on a variety of aspects of PWS, medical, social, therapeutic, and so forth. And these are surveys that you go in and complete, but they're also updatable. So as your child ages, you can update the information in there. Researchers routinely make requests for information that is de-identified to use in their research to understand PWS. So the more we have representation of the entire PWS community, the better off we are in answering those important critical research questions. So, we have a number of goals, and what we also do with the information is share it back to you as parents in the form of infographics, and there's just one example up here that shows, an infographic on skin picking, but we routinely share information from the registry back to you so you know how your experience compares to others who have answered those same surveys in the registry. One of the really critical pieces that can't be understated is how the registry supports clinical trials and clinical care. We use this as a tool for recruitment for clinical trials. We share information out to families about happenings so that you can be informed at all times of what's available. Again, we provide data to help inform protocol development. We use it to help with regulatory submissions and develop standards of care for clinicians. And further, the registry is used to validate outcome measures. So understanding how somebody benefits from a clinical trial is measured through outcome assessments. So there are a number of measures that are in there that are being validated that then when somebody is in a clinical trial, the FDA can recognize these tools as valid measures of change over time when using a particular pharmaceutical. So examples are the HQCT, which you'll probably hear mentioned many times throughout this conference. It's a hyperphagia questionnaire in clinical trials. It's been used by many drug studies thus far, as well as the PADQ, PWS Profile and Food Safe Zone, which are being validated among others. So the more opportunity you have to contribute to that, the more information we have to improve those outcome assessments. Another example of how the registry has been very impactful is DCCR has used some of the natural history study in the global registry in the form of the Path for PWS study in their submission for their new drug application, and comparing individuals on DCCR medication compared to those on placebo, compared to those in the registry. And that's been very informative as they've submitted that application. The FDA has found that information to be very useful. So I cannot stress enough, if you are not currently in the registry, please create an account. If you need help with that, you can email info@pwsregistry.org. The email is there in the middle panel at the bottom. You can also find myself or Jessica Bahanowicz while we're here. We're happy to help you with that. If you have a registry account and you haven't been in the registry in a little while, it's the perfect opportunity to go in and update, because we know that as our children age, their experiences in living with PWS change. So we want to reflect that experience. So with that, I'm going to close out the session and thank all of you for joining us today. We have the next session is coming up at 3:45, Advancing Hope in Clinical Trials for People with PWS, and that is going to be located in this same room, Grand Ballroom 1 and 2. So thank you again, and we'll see you back here at 3:45.